pleasure to introduce you to Antonio Marzollo, Chair of ESID Junior's Working Party, Pediatric Immunologist in Padua, Italy.
Hello, good afternoon, and thank you for having me here. I was given this talk overview of primary immune deficiency, but as you all know, immunologists like to be very precise. So I am very precise, and I need to change the title of my talk because we changed the title of our field from primary immune deficiency, which is more about infection and deficient immune system, to inborn errors of immunity, highlighting the genetic part and the fact that the clinical presentation can be very, very different. So what I would like to do for you as an overview, I would like to go through the basic elements of the human immune system and what happens to the patients when we lose them. Look where to find a patient with inborn errors of immunity, because they are usually hiding. And what basic test should I order? I hope that at the end of this presentation, I will have the answer. You will have the answers, at least the basic answers. Because the disclaimer, I will try to do my best to simplify the inborn errors of immunity field, but it's very, very complex. So the rules and most of what I will be saying is okay for 90 to 95% of the cases, which I think is very good, but there will always be a case that's different. So I will have a solution at the end also for that one. What are the basic elements of the human immune system in my idea? This is classification which I invented for the purpose of this talk. So there are other 20,000 different classifications. So I start from B lymphocytes, T lymphocytes, then granulocytes, innate and intrinsic immunity, and regulatory elements. So let's start. B lymphocytes. What do B lymphocytes do for a living? Their most important role is to produce antibodies. So, as it comes, no B lymphocytes, you will have a defect of antibodies. But the defect can be either in the dose, so very little antibodies, or in the specificity, so the dose is okay, but they are not working properly. And so, if you don't have B cells or B cells are not working, you call those primary antibody disorders. And you have two main kinds, which is one is when the B cell is completely absent, so immunoglobulins are all zero, and you have A-gamma globulinemia, which is quite a Greek word, so you should be able to decode it a lot better than I can. When the B cells are present but not really functioning, and so IgG is low, you call it common variable immune deficiency. So what are antibodies for? Antibodies protect mainly against bacterial infection and respiratory infections. If IgG is very, very low, you can have also sepsis and severe systemic infections. Okay, so this is it for B lymphocytes. Let's go to the T lymphocytes. What do? They provide cellular immunity, which is mostly the CD8 positive T cells, or help B cells and the other antigen-presenting cells to work properly. And this is the CD4 T cells, which are known as helper T cells. But as you see, there is the second line. When there is a T cell defect, there is always a B cell defect. And this is why we call it combined immune deficiency. When I first entered the field, I was working, okay, there are the B cell defects, where the T cells defect. Then I realized that it's combined, which is known as CHID. But if the T cells are very low in the first year of life, we call it severe CHID, which is SCID. And SCID is an emergency you really do not want to miss in your patients. What do? Well, they are all in for for most of the pathogens. So you have viruses, you have fungi, you have bacteria, because you remember that you have all the consequences of the B cell defect. Then come the granulocytes. The granulocytes are the first line of defense against bacteria and fungi. They are involved in wound healing, and they are very important for mucosal integrity. Also here, there is the possibility of not having granulocytes and neutrophils, which is called neutropenia, or if neutrophils are not functioning. And also this comes into two flavors. If there is no intracellular killing, so they can phagocyte the bacteria, but they cannot kill it, we call it chronic granulomatous disease. If there is no extravasation, it means that the leukocytes remain in the blood but cannot get into the tissues, we call this leukocyte adhesion defects. So what are granulocytes for? Bacteria and fungi. But it's a little bit different. Once I heard this phrase, which I really like, which is when I can't pronounce the name of an infecting organism, I think of granulocyte defects, because they come with Serratia marchescens, which I did not know before thinking about granulocyte defects. So all the names that are really quite fine. But it can be a little different, the clinical phenotype, whether you're talking about neutropenia, which is mostly risk of sepsis and the mucosal integrity, while a functional defect is more likely to cause localized infections and delayed wound healing. So also here, from the phenotype of the patient, we can see what is more like neutropenia versus functional defect. What is innate and intrinsic immunity, which is quite a new field within the field of inborn errors of immunity. And these are defense mechanisms which are not dependent on adaptive immunity. This is, I think, is the best definition. I have looked it up and I read several others. But one of the interesting things is that here we are not talking about cells that are in the blood. We are talking also about cells that are all over the body. So we are talking about pneumocytes, so cell of the lung. We are talking about gut cells. And so you cannot really most often correct this defect with a hematopoietic stem cell transplantation, as you can change only the blood, but you won't change the lung or whatever organ you need to change. Lesions in the innate immunity underlie specific severe infections, so that the phenotype of the patient is can be a single very severe infection while the patient was otherwise healthy. So as long as the patient did not encounter that single organism, they can live a normal life. And these defects are often hard to detect on basic immune workup, because, well, we are looking at cells in the blood, which, as Marianna told us yesterday, it was very nice. They are just at the stop of the cells that pass there, but we do not have the full picture. And sometimes often the defect, to detect it on the blood cells, you need specialized functional testing that is not always readily available, and genetics is often the answer for these, to diagnose these defects. I would put in here, but this can be long discussed, also complement defects and asplenia, which are easier to diagnose, because just checking if there is a spleen or if there is no spleen, and checking the complement tests, but they are also very specific for a specific group of pathogens. So what agents do have a known yet innate defect? So severe non-tuberculous mycobacteria, HPV, so severe warts, herpes simplex encephalitis do have quite a long list of defects associated, mucocutaneous candidiasis, encapsulated bacteria, and here you find the complement and the spleen, trypanosomiasis, and respiratory infection. And when COVID came out, there are several innate immune defects that are the cause of severe COVID. And I'm sure that there are many more to come in the future, because when the more disease, more severe disease will be cracked in this with this set of mind. Then there are the regulatory elements. As up to now, we have seen what the immune system can do, but the immune system is a very, very powerful machine. So they need breaks. What do regulatory mechanisms do? They avoid unnecessary activation of the immune system, or if the system has activated, they just switch off after the activation. So what defects can be there? There are quite a few that are just isolated immune dysregulation. So you do not get infections, you just get that the brakes are off, and the problem of the patient is that is mainly due to the immune system attacking the body. But as you know, that the immune system can get very frustrated if it cannot destroy a microorganism. So if he misses the target, the immune system, it usually exaggerates elsewhere. So immune dysregulation can be a cause of, can be a feature of most inborn errors of immunity. So you see autoimmunity in B and T cell defects, autoinflammation in neutrophil function disease, and more and more. So what do we put under the large umbrella of immune dysregulation, which will be better explained by Isabel soon? We put there autoimmunity, we put there autoinflammation, we put there HLH, we put there allergy, but we also put there lymphoproliferation and some kinds of cancer. So just to briefly recap these points, you have, for the bacteria, you have the B and T cells, and the granulocytes. The subset of bacteria is a little different. The viruses is mostly T cell. Then the fungi, it's T at the granulocytes. Also, there are different kinds of fungi. There's pneumocystis, which is mostly T lymphocyte. And then there is immune dysregulation all over the place, or just in the immune dysregulation defects. The innate immunity, there is one for bacteria, one for virus, one for fungi, so you will have it all in all flavors. Okay, so now we have an idea of what kind of infection, when we start from the infection, we know where to look in the immune system, but where to look to find a patient with inborn errors of immunity. It is often like this. You have many people on the beach, and you need to find the rare and generally monogenic disease, which hides, and you don't know if you know this game, you need to find this guy with the striped shirt. And so in the clinics, you see many patients, and you need to pick the right one and give him diagnosis or her. I think that the best idea is to see how patient presented in the first place to know where to look. So when you take the ESID registry data, which have been recently published, and this is 16,000 patients, you have that around 70% are just PID, so primary immune deficiency, so an infection without dysregulation. But you have more than 20% that come with dysregulation, either with infection or without infection. And please note that there is a small minority, but it's quite relevant, with family history only, because don't forget, these are rare genetic disease. And this is quite true across all the ages, so also for adults. Some time ago, and these are super famous, the Jeffrey Model Foundation published the warning signs, both for children and for adults. But if you go through them, you see that 9 out of 10 are based on infections. This is a good way to know how many infections are, let's say, normal, but is not a great way because you miss here all the immune dysregulation. So what I do in my mind, and this is absolutely not validated, but it works in my mind, I just look for signs related to the immune system. So when I get cold, from gastroenterology ward or neurology, I look either for infection or immune dysregulation. Is there infection or immune dysregulation? And well, if they call me, most likely there will be. Immune dysregulation comes in many flavors, so don't forget that there is allergy, there is HLA, there is lymphoproliferation, so there are quite a few. And then I think, well, I'm looking for Waldo, so I'm looking for a rare disease, which should be at least unusual in type, severity, frequency, or that simply does not respond to treatment. And this is because if you have 100 patients presenting every day with this manifestation, this is quite unlikely to be a monogenic rare disease. So how I judge the unusual, I look at the face of the treating physician, which is when it's like this, they tried everything on that patient, it never worked. It's just similar to the other patient, but really nothing works. I'm afraid, and I suspect a primary immune deficiency. Then I add to this family history, because if you have two brothers and two physicians with that face, well, it's the moment to suspect and test. So what test should I order? This has been long debated, but I think that we need to start and look at the registry. In the registry, what types of defects are there and which ones are the most frequent, because you want to rule them out first. You want to rule out the most frequent and the most severe. So if you look there are 55% of antibody deficiency and 26% of combined, as I told you, combined come with a bit of B-cell deficiency defect. Then there are some immune dysregulation, phagocyte, and innate immunity. So I would be really happy if in the first line testing, I would cover at least the 80% with primary immune deficiency and combined immune deficiency. So how do I reason? One of my mentors during my training was Capucine Picard in Necker, who published this, unfortunately only in French, but I really like it, this review. And so this is how she teaches how to do it. So it's hers. And so I start by the full blood count, which is probably one of the most interesting thing, because you can look at the number of lymphocytes, number of neutrophils, so neutropenia is already gone or ruled in or ruled out. Look at the number of monocytes, because there are defects that are specifically on the monocytes, such as GATA2 deficiency. And well, you make a super diagnosis. You just open the book, see this complete blood count, well, GATA2. And you can also get a flavor of immune dysregulation, as there is might be cytopenia. Then I look at IgG, IgA, and IgM, just to see if there is a predominantly antibody deficiency. And I look at vaccine serology just because to look at how the interaction between the B and T cell work. And these are tests that you can get in almost any hospital in any country, also local hospital. And then there is the big debate. Should I order lymphocyte subsets? Well, lymphocyte subsets are, I believe, either there are 0 or you put 10 immunologists in a room and they can discuss for 1 hour about the meaning of the lymphocyte subsets. So if you are not completely confident that you are going to be able to interpret those lymphocyte subsets, it's better to ask before ordering, especially the fancy ones that in the lab take time and might the lab personnel might get nervous if you ask something that's not really appropriate. So I would suggest to do it always as first-line testing under the age of 1, because you really do not want to miss a skid. But I think there are second-line tests for all other patients. And then, so these rules, I told you, work for the 90% of patients. And so you have your first-line tests and your clinical situation. And you need to tell me how you feel. You feel relaxed. Well, PID was probably not, the patient was not that rare. I just did it because the mother was complaining, but well, I somehow relaxed. Never forget that PID can manifest and have more and more and more disease over time. So reevaluate your feeling over time. But if you really do not feel confident, talk to your immunologist, because this is the right moment, not after 10 years of sending lymphocyte subsets and not knowing how to interpret them. It's important. Immunologists at least it's their job to answer the phone, listen to stories, and tell, well, this is this gene, I want this. So we actually like this. And based on the phenotype, we might ask lymphocyte subsets, but specific ones. We might ask neutrophil function test, which is done quite often because here we did not exclude any neutrophil function disorder up to now. Complement function, gene sequencing, it's becoming more and more available and easy to obtain and can really change, get to the diagnosis very quickly if it works. I mean, if there is that diagnosis there. And functional testing, but please talk to your immunologist before ordering functional testing because they can be, if lymphocyte subset can be difficult to interpret, functional testing is difficult to interpret. So I thank you very much for your attention.